In this chapter, we'll take a look at medical nutrition therapy for thyroid and related disorders. So looking at thyroid disorder, 20 million Americans have thyroid-related disorders, and more than half are undiagnosed. Individuals with diabetes have a higher prevalence of thyroid-related disorders, including hypothyroidism, hyperthyroidism, pituitary disorders, and adrenal cortex disorders. Now we looked at this diagram previously, and so now we're again looking at endocrine function, but specifically we're looking at the thyroid gland, right, that butterfly-shaped gland in the neck, where we have the parathyroid and thyroid, which again we can see from this key have solely endocrine function. So looking at the thyroid gland, remember we have a small butterfly-shaped gland located in the neck just below the Adam's apple. So it creates two iodine-containing hormones. We have thyroxine, which is our T4. So major hormone secreted by the thyroid named for its 4 molecules of iodine, and triiodothyronine or T3, so the most predominant and most active thyroid hormone named for 3 molecules of iodine. The thyroid gland also produces calcitonin, which is the hormone that helps regulate the amount of calcium in the blood. So again, here we can see the location right below the Adam's apple, again the butterfly shape. So the thyroid gland makes, stores, and releases thyroid hormones, which affect essentially every organ, tissue, and cell in the body. And functions include fat and carbohydrate metabolism, body temperature regulation, and heart rate. We also have the pituitary gland, so this is located at the base of the brain. So we have the anterior pituitary gland, and this regulates several physiological processes including stress, growth, reproduction, and lactation. And the posterior pituitary gland stores and releases vasopressin and oxytocin, which are synthesized by the hypothalamus. This also secretes the thyroid stimulating hormone, which is what actually stimulates the production of T3 and T4. So the pituitary gland obviously isn't the thyroid, but it does play a direct role in the thyroid's function. So again, here we can see the hypothalamus and its relationships to the anterior and posterior pituitary, which is what we're focused on, with that posterior pituitary again actually communicating with the thyroid gland. So we have the hypothalamus pituitary thyroid axis. So the hypothalamus again, so a tiny cone-shaped structure located in the lower center of the brain that communicates between the nervous system and the endocrine system and the pituitary gland and the thyroid gland. And so we have what's known as the hypothalamus pituitary thyroid axis. So again, the HPT axis, which is part of the endocrine system, responsible for the regulation of metabolism. Now looking at constructing thyroid hormones. So we're going to need tyrosine, which is a required amino acid for thyroid hormones. Iodide is required for thyroid hormone production and is oxidized to iodine in the thyroid gland. And we have thyroid peroxidase, or TPO, which is an enzyme responsible for thyroid hormone production. And so thyroid hormones are then secreted into circulation upon completion of their construction. And so here we have our construction of our thyroid hormones, again with T3 and then to T4. Now looking at the adrenal glands, so these are located above each kidney, and their primary responsibility is to govern the body's adaptation to stress. And so we have the adrenal medulla, which is the inner portion, and this is part of the sympathetic nervous system, secreting epinephrine, norepinephrine, and catecholamines. And the adrenal cortex, which is the outer layer, and this secretes more than 50 adrenocorticoid hormones, including aldosterone and cortisol. Now looking at our lab values, TSH reference range is 0.2 to 5.5, and TSH in the upper range is associated with a greater risk of developing hypothyroidism, and decreased TSH combined with normal to high T3 or T4 suggest hyperthyroidism. T3, the normal value is 100 to 200 nanograms per deciliter, and T4, the normal range is 4.5 to 11.2 micrograms per deciliter. And again, low T3 and T4 are associated with hypothyroidism. Now the way the thyroid works, so the hypothalamus signals the pituitary gland to make thyroid stimulating hormone, or TSH. The pituitary gland then releases TSH, and so the amount depends on how much T4 and T3 are in the blood. And if there is not enough T4 and T3 in the blood, the TSH gets higher and higher. So in essence, right, the TSH is knocking on the door saying, or it's an alarm clock saying, hey, wake up, hey, produce T3 and T4. If you turn off the alarm clock and wake up, if you then produce T3 and T4, TSH will fall. Now, if you've been up for too long and you never went to bed and T4 and T3 remain elevated, then TSH levels, right, will continue to fall. Now, finally, the thyroid gland regulates its production of hormones based on the amount of TSH it receives. So if the thyroid gland is diseased and is releasing too much thyroid hormone, then TSH levels again will fall below normal and we'll see hyperthyroidism. And if the diseased thyroid gland can't make enough thyroid hormone, then TSH levels continue to remain high and the alarm clock continues to ring as no one's actually answering the alarm clock. And this is what we see with hypothyroidism. Now here we have common causes of hypothyroidism. So you'll see Hashimoto's, lymphocytic thyroiditis, thyroid destruction, pituitary or hypothalamic issues, pituitary injury, and medications. So looking at hypothyroidism, so looking at our epidemiology, is 4.6% of the U.S. population. It's most prevalent in the elderly and is more common in females. And so the etiology, we have iodine deficiency as our most frequent cause, though, worldwide. But autoimmune thyroid disease is most common in the U.S. So again, I know because everybody's wondering, like, why did we bother putting iodine in all of the salt? Because the rest of the world didn't, and that actually is causing hypothyroidism. In the U.S., because we have iodine, autoimmune thyroid disease is the most common. Clinical manifestations of hypothyroidism. So again, depending on the severity and the level of hormone differences, can be subtle or present with no symptoms, but we can also see decreased metabolic rate, cold hands and feet, intolerance to cold, weight gain, easily fatigued, slow heart rate, goiter, slow reflexes, diminished alertness, depression, pitting edema, abdominal distension, and myxedema. Now looking at our pathophysiology for hypothyroidism, so we have the enlarged, chronically inflamed thyroid gland becomes non-functional. Again, the most common cause is Hashimoto's thyroiditis in the U.S. And so what we see is the presence of thyroid peroxidase antibodies, which indicates that the immune system is attacking TPO in the thyroid gland tissue. Now the triggers of hypothyroidism, so again we said aging, so there's an increased incidence with age. So by 60 years of age, 9 to 17% of men and women have an underactive thyroid. Pregnancy, so 1 out of every 50 women will be diagnosed with hypothyroidism during pregnancy. And adrenal stress and oxidative stress, so underactive thyroid is often related to adrenal fatigue or adrenal stress, and the decreased ability of the adrenal glands to respond to stress. So looking at chronic adrenal stress, this can cause altered communication between the brain and hormone-secreting glands, increased thyroid binding protein activity so that thyroid hormones cannot get into the cells and function properly. It prevents the conversion of T4 to the active T3, can interfere with detoxification pathways, and the cells can lose sensitivity to thyroid hormones, and weakened immune barriers of the digestive tract, lungs, and brain can lead to poor overall immune regulation. We're also concerned with cortisol, which is a hormone produced by the adrenal gland, and so this raises blood glucose when blood glucose drops too low. And so if this happens repeatedly, the adrenal and thyroid glands can become exhausted, leading to functional hypothyroidism. And so constant cortisol production weakens the GI tract, making it more susceptible to inflammation and infection. And so this is again how we hear that how stress is bad for you. This is the physiological explanation. And so the treatment for hypothyroidism is exogenous thyroid hormone. So most common is levothyroxine or Synthroid. Now again, we do need to look at some drug-nutrient interactions. So again, Synthroid needs to be taken without food. So we usually recommend first thing in the morning. Now it may decrease the absorption of iron, calcium, or magnesium, so those may need to be supplemented. And soy, walnuts, and high fiber may also bind with and decrease the absorption of the drug. So goitrogenic plant foods can exert anti-thyroid activity through the inhibition of TPO. This includes things like cauliflower, broccoli, cabbage, Brussels sprouts, and radish. And so cruciferous vegetables may yield goitrin, which interferes with thyroid hormone synthesis. And so soybean has goitrogenic properties as well when iodine intake is limited, as isoflavones inhibit the activity of TPO and can lower thyroid hormone synthesis. So iodine is added to soy-based infant formulas, and the best practice, though, is to avoid an excessive soy intake. So we said that iodine deficiency is the most common cause for hypothyroidism worldwide, and an inadequate intake of iodine impairs thyroid function. Now, iodine supplementation, though, with Hashimoto's disease may actually exacerbate the condition, as iodine stimulates the production of TPO, which actually then increases the levels of TPO antibodies. Now, what we also see is what's known as cretinism, which is congenital hypothyroidism caused by severe iodine deficiency, and this results in dwarfism and mental retardation in children, and this can affect 1 in 4,000 newborns. Low iron status may cause low thyroid function, as TPO requires insertion of heme iron in order to synthesize thyroid hormone. We also know that selenium is a cofactor needed for 5-deiodinase, and so if selenium deficiency, then there will be a decreased ability to deiodinate T4 to T3, resulting in reduced T3 levels. On the flip side, excessive selenium intake may have detrimental effects on thyroid hormone metabolism as well. And so a suggested safe level is 500 micrograms or less per day. Now looking at polycystic ovary syndrome, or PCOS, also called polycystic ovary disease. So this is an endocrine disorder characterized by hyperandrogenism in large polycystic ovaries. And remember, a cyst is a small fluid-filled sac, and insulin resistance. This is the most common hormonal reproductive problem in women of childbearing age and affects approximately 3 to 12% of women in Western societies. And unfortunately, the cause of PCOS is unknown. So here we can see, and again, I'm not a radiologist, but you can see that clearly, right? So you can see the large black circles. Those are actually the cysts. That's the fluid, so because of that different density. Again, I'm not a radiologist, but even I can tell you that's not normal. Now, it is normal that women can have 1 to 2 cysts, right? And they're transient and they go away and they come and go at times. That's not the same as PCOS, right? Where there's a very large number and they're very persistent. Symptoms of PCOS include infertility, infrequent or absent menstrual periods, increased growth of hair on the face, chest, back, toes, and stomach, acne and oily skin, pelvic pain, weight gain or obesity, high cholesterol and blood pressure, and male pattern baldness or thinning hair. Now again, looking at the reason for this pathophysiology is we have elevated levels of androgens, and so we see is what's known as hyperandrogenism, which is responsible for the reproductive and menstrual abnormalities of PCOS. Now we also see hyperinsulinemia with insulin resistance, and again this triggers an increase in androgen production. So again we also see impaired glucose tolerance and hyperlipidemia. So the diagnosis is confirmed with a pelvic exam to assess if the ovaries are enlarged and ultrasound to examine the cysts. And looking at the treatment, there is currently no cure, with a focus though on managing symptoms. So oral contraceptives are common to regulate hormonal cycles. Oral hypoglycemic agents can help regulate insulin and its effects on glucose, with metformin frequently being prescribed for patients with PCOS. Fertility medications, medications to reduce hair growth, surgery, and a focus on maintaining a healthy body weight. And so the goal of MNT for patients with PCOS is dietary modifications to enhance insulin sensitivity. So we want to restrict refined carbohydrates and total calories, consume high fiber foods, eating small frequent meals, and vitamin D and chromium picolinate supplementation has been shown to improve glucose tolerance, insulin secretion, and insulin sensitivity. Looking at hyperthyroidism, so this is an overactive thyroid gland. Graves' disease is the most common cause in the US. So again, similar to Hashimoto's, this is an autoimmune disease in which the thyroid is enlarged and overactive. producing excessive amounts of thyroid hormones. And signs and symptoms include red, dry, swollen, puffy, and bulging eyes, heat intolerance, difficulty sleeping, anxiety, and goiter or thyroid enlargement. And excessive thyroid hormones can cause thyrotoxicosis. Other causes of hyperthyroidism include toxic adenoma, toxic multinodular goiter, and thyroiditis. So here we can see the bulging of the eyes caused by hyperthyroidism. Now again, we can see here the increase in size of a normal thyroid versus an enlarged thyroid. So again, what causes this? So an inflammation can cause excess thyroid hormone stored in the gland to leak into the bloodstream. And adenomas of the thyroid produce excessive T4, so that's cancers of the thyroid. With Graves' disease, antibodies are produced by the immune system, and these stimulate the thyroid to produce excessive amounts of T4. And antibodies also stimulate iodine uptake, protein synthesis, and thyroid gland growth. Graves' disease results from both environmental and genetic factors, with genetic factors contributing 20 to 30%, and environmental factors including a history of infections, excessive iodide intake, stress, being of the female gender, steroids, and toxic exposure. And so looking at stress, acute stress-induced immunosuppression may be followed by an immune system hyperactivity, which could precipitate an autoimmune thyroid disease. Hyperthyroidism can accelerate metabolism significantly, causing sudden weight loss, which I know what you're thinking is, that sounds like a good thing. The problem is there are other clinical manifestations, which includes things like palpitations, nervousness, irritability, sweating, hyperdefecation, heat intolerance, oligomenorrhea, weight loss, drooping eyelids, rapid or irregular heartbeat, bulging eyes, AFib, and muscle weakness. So looking at the medical management of hyperthyroidism, we have anti-thyroid medications which are used to prevent the thyroid from producing hormones. We have radioactive iodine therapy and thyroidectomy. Now, unlike hypothyroidism where we needed to avoid goitrogenic foods, there's no specific diet for hyperthyroidism. That being said, after going through radioactive iodine therapy treatments, patients will actually develop hypothyroidism and then they would need to follow a special diet. So looking at considerations for managing imbalances. So we want to make sure that we provide adequate precursors for the formation of T4. And so iodide is a limiting nutrient for the production of T4. So again, getting adequate but not excessive amounts of iodide through seafood, iodized salt, and sea vegetables. Although tyrosine supplementation has not been found to be beneficial, since it's a non-essential amino acid, we can actually produce additional tyrosine as long as we consume adequate protein. To improve the conversion of T4 to T3, selenium and zinc help support proper deiodination by 5-deiodinase enzyme. And so 5-deiodinase is the enzyme that removes one molecule of iodine from T4 to form T3, and it is selenium dependent. And selenium supplements result in improved deiodination of T4, which may improve ATP formation by supporting improved mitochondrial activity. And so sources of selenium include Brazil nuts, snapper, cod, halibut, yellowfin tuna, salmon, sardines, shrimp, mushrooms, and barley. And so studies show reduced thyroid hormone concentration when zinc deficiency is present. Now again, we want to make sure that we're using caution with supplements. So for example, lipoic acid reduces the conversion of T4 to T3. So again, you want to make sure you're getting a good history from your patients. And maintaining vitamin sufficiency, so vitamin D helps to establish immune balance and prevent the production of autoantibodies, and vitamin D deficiency is associated with Hashimoto's disease. Looking at pituitary disorders, so pituitary disorders are a result of a hypersecretion or hyposecretion. The most common disorders include pituitary tumors or adenomas found in the pituitary gland, which are usually benign, acromegaly, which is enlarged extremities due to hypersecretion of growth hormone, Cushing's syndrome, which is caused by excessive circulating cortisol, and diabetes insipidus, which is an insufficient production of antidiuretic hormone by the hypothalamus. So looking at Cushing syndrome, so this is a disorder that occurs when the body is exposed to high levels of the hormone cortisol. Now we have endogenous Cushing syndrome, which results from chronic and excessive production of cortisol by the adrenal cortex. And exogenous Cushing syndrome is due to the administration of glucocorticoids in large dosages for several weeks or longer. Now, Cushing syndrome is caused by a pituitary or adrenal tumor. And so again, signs and symptoms include weight gain, easy bruising, depression, muscle loss, and weakness. And there's no special diet, however, weight management may be indicated, so especially if it's due to corticosteroid use, then we know that there is an increased risk of weight gain. Next is Addison's disease, which is a disorder in which the adrenal glands produce insufficient steroid hormones. So we have glucocorticoid hormones such as cortisol, which maintains blood glucose control, suppresses immune response, and helps regulate the response to stress. Mineralocorticoid hormones such as aldosterone, which regulates sodium and potassium, and sex hormones such as androgens and estrogen. So Addison's disease can be caused by an injury to the adrenal cortex through autoimmune disease, infections, or things like hemorrhage, blood loss, and tumors. And signs and symptoms include poor appetite, fatigue, low blood pressure, nausea and vomiting, and darkening of skin on the face and neck. And again, there's no special diet, but if patients live in a warm climate and have increased losses of sodium through their sweat, they may need to increase their salt intake. All right, let's take a look at some practice questions. So number 1, a typical reference range for TSH in many labs is, and this is 0.2 to 5.5. Number 2, heavy menses, dry, coarse hair and skin, and weight gain are most commonly associated with, and this is answer choice D, hypothyroidism. Number 3, tapazole and Northix are most commonly used in the treatment of patients with, and this is answer choice B, Graves' disease. Number 4, Cushing syndrome is characterized by, and this is answer choice A, excess cortisol. And number 5, one nutrient that is critically important for establishing immune balance and preventing the production of autoantibodies is, and this is answer choice B, vitamin D. Thank you for your time, and I look forward to your questions.